my physician's assistant said, well, this is the only slide I need to show because I was asked to talk about surgical treatment of breast cancer, and I guess this summarizes that aspect of it. First off, the conference presenters, I had said, well, let's talk about the cutting edge treatment for breast cancer, and they changed it to leading edge. I guess was a little less violent, but as a surgeon, I have no problem with cutting edge, so I changed it back. Anyway, in 1981, when I left Sloan Kettering, there were 3 operations that were done for breast cancer. You had a breast biopsy to diagnose it, which was usually an open breast biopsy, and then you had a radical mastectomy, removing the breast and all the lymph nodes or modified, and the muscles on the chest wall, or a modified radical mastectomy, which is a little less aggressive. But thinking about it, in 2015, we're doing a lot more, and hopefully a lot better. You notice that number 2 and number 7 in the right-hand column, radical mastectomy and open breast biopsies, are largely things of the past. I rarely am doing these in my practice. And as my assistant said, well, now you can send everyone home and let them think about that, and those are the surgical options for breast cancer. But, of course, it's more complicated than that. And if I can figure out how to advance this. It worked. Well, it's more complicated because breast cancer is the most common cancer among women worldwide, and of course a source of great concern. That's why we're here today. So what do we do? Well, let's digress a little. I always talk to patients about what they want and what they need. You really should always have what you need, but very often you really don't need what you want, as confusing as that might sound. And probably one of the best examples from the past was the story of bone marrow transplants. In 1991 in California, a young woman had been told that her breast cancer was now involving her bone marrow, and she had failed all her chemotherapy, radiation treatments. And the doctors at the medical center she was at said, well, we have this new procedure, bone marrow transplant. Of course, there was no evidence that it had been validated as a successful treatment for breast cancer, but it was something that looked promising, and this was something she might want to consider. And we'll talk about the dynamics of all this a little later. And she applied to her insurance company. Insurance company said, no way. This is an experimental procedure. It has no proven benefit. We're not doing it. So she then went ahead and raised $212,000, funded her own treatment, and went ahead and had the bone marrow transplant, and then sued her insurance company for denial of services, and won some incredible judgment of close to $100 million. It was, and then, of course, it comes out in 2000, 9 years later, in the New England Journal, that this is a totally ineffective treatment, and it doesn't really add anything to our armamentarium against breast cancer, and in fact probably does more harm than good. But she wanted it because she perceived that it was something that she needed. And this gets us into the reality check, which I think needs to form the basis of how we understand everything I'm talking. It's very hard to find a picture of a house with 4 floors, but this, coming from the Kabbalistic mysticism of the Middle Ages, is my way of looking at reality, and I call it Neo-Kabbalism. And we look at the, I think I have a pointer. If we look on the first floor, I like to say that's the grounded floor, where it's the real physical world, where we are, where we know things, we can touch things, we can see things. And that's where doctors operate. Doctors operate, when I talk to a patient, I have to talk to them about what I know will happen in the physical world, something I can touch. Something that's been documented, something that's real. But the fact is that most of the patients are on the second floor. They're in the area of emotion. They're going through a rough time. They're going through a very emotional experience. And in fact, they don't have the knowledge of the first floor when it comes to their breast cancer or their treatment. And they need to somehow make a decision, and it's being made on really on a more emotional basis. It's how they feel. And then the third floor, if you go on with the analogy, is the world of ideas, the world of rational, the world of thought. And then the top floor, of course, is the spiritual, where you connect with a higher deity if you're so inclined to believe. I happen to. So, what you need. So this is my simplified way, and I jokingly said this to a colleague once. He said, what do you need in order to, what's the answer to curing breast cancer? In this day and age, what do you do? And I said, well, first off, you need good luck. Unfortunately, there are some breast cancers we don't understand. We don't understand everything about breast cancer, and they're gonna do you harm, and there's just nothing we can do about it. Like that poor, unfortunate woman who had the bone marrow transplant that she thought she needed. There was other things she needed, and I refer you to Atul Gawande's book, Being Mortal, which is on the bestseller list, which is worth it for every cancer survivor family, and every physician for that matter to read and understand what goes on when we're faced with something that threatens life or we're at the end of life. And then the second thing is a physician who, one, recognizes your problem, two, knows what to do for it, and then does it at the right time in the right way. And think about that. So what you need, how does the physician know what to do? How does he know, what's the correct course for things? Well, we need to be on the first floor of that house. We need to look at outcomes. We need to look at evidence. And my practice in the last 5 to 10 years, has been converted to evidence-based practice. I look for guidelines. I look for direction that has proven outcomes, where I know if I do X, Y will happen most of the time. Nothing's 100% in medicine. So evidence-based medicine, outcomes in the physical world. Now that's fine for me, but when I'm talking to a patient, we're addressing a different dimension. We're addressing a lot. We're addressing emotion and how they feel. So interestingly enough, I saw 5 or 6 new patients who were afflicted with breast cancer this week, and we had to discuss what we might want to do for them. And I asked them, well, how do you feel about the treatment? What is going to make you feel safe and comfortable? I mean, you have an option. You can do mastectomy. You can do lumpectomy. What's going to make you feel comfortable? So for a patient who had already had a breast cancer and was faced with a second, she said, I don't want to go through this again. What's going to make me feel comfortable is to have mastectomy. But another patient who was a younger woman in her 30s, she said, I don't want to lose my breast. What's going to make me feel better is to maintain my appearance and be able to go on normally with my life. And if I can offer her equivalently responsible treatments, then she's going to base her decision in terms of how she feels about it. And it's my responsibility, and it's my moral responsibility as well as professional responsibility to guide her in a way where she can make that decision for herself. Okay, my 2 sources of guidance in life. One spiritual from the top floor, and the other my breast cancer Bible, and probably the document or the resource that I refer to most is the National Comprehensive Cancer Network Guidelines for Treating Breast Cancer. Even though I've probably treated somewhere between 2,000 and 3,000 women with breast cancer, and I have a large experience, which I don't ignore, this is a result of 16 or 20 or so institutions getting together with experts and looking at all the data and saying, what gives us the best result for each situation? And it's amazingly enough, they've managed to to define just about most of the situations that we see in patients who present with breast cancer. So I can say, well, I know if I do this, I'm going to get this is going to give me the best result. So I know if a woman has the earliest form of breast cancer, ductal carcinoma in situ, you may have heard of that, where just the surface of the milk ducts in the breast are involved, and it hasn't spread out into the breast tissue, it hasn't spread to the lymph nodes or elsewhere in the body. We know that woman, you know, that it's very unlikely she'll ever die or have a bad outcome from her breast cancer, so we need to do the right thing. If it's in a tiny spot, then we don't need to do a mastectomy, and I try to help women understand that. However, we know that sometimes they're diffuse and extend for a good part of the breast, and we're forced to do a mastectomy. All of these things are considerations that you need to consider. So being a breast surgeon isn't so simple anymore. I need to look for sources where I can assure my patients of the best outcomes, and I need to do the right thing for them. So we look at workflow. Workflow is a term that I picked up from my hobby, photography, and it's important. It basically tells us what is our order of doing things in order to take care of the problem. Now, I always like to consider, you know, when I do workflow, I always want to leave options open. I don't want to take things off the table. I don't want to start with doing a mastectomy, which takes lumpectomy off the table. I want to do things that leaves the woman open with her choices and options still available to her. So first is imaging diagnosis, and then biopsy, then treatment planning, which requires a team, and we'll get into that, then the treatment itself, and then the follow-up, which is also a survivorship. Okay, workflow imaging. The current standard of care is mammography, now 3D tomosynthesis, which is a new form of mammography that doesn't involve injection of contrast materials with the attendant complications, and sonogram. Joan London had a report that was reported by the Herald this week that I was reading, and she said, you know, I had dense breasts and the mammogram didn't show it and the sonogram saved my life. Well, I said, okay, we do that. We know our team member, the breast radiologist, knows that if a woman has dense breasts, even if she's older, on her mammogram, that she's going to have a screening sonogram. And very often that'll be the only way they pick up the tumor. And this happens every week in practice. Now, what about these other things? These are things women commonly want and ask for. Breast MRI, PET scan, bone scan, CAT scans. And the fact of the matter is they're often expensive. They're often overly sensitive, finding things that aren't in fact there. They often involve injection of contrast agents in order to be effective, like MRI must be done with gadolinium, which is the contrast agent which you need to inject in order to really get an effective exam. There are places for these things, but the mainstay is still mammography and sonography. But you say, hold it, mammograms aren't any good. We've been reading about that in the newspapers and all that. Nonsense. That's nonsense. Yes, mammograms don't detect all breast cancers, but they detect probably the majority of breast cancers, especially supplemented with sonography and with competent physical exam. That is the mainstay, yes. Yes to mammogram, preferably 3D tomosynthesis, the newer form. Yes to sonogram. That's not what we're talking about today, so let's go on. Biopsy. In my practice, over 90% of breast cancers are diagnosed on needle biopsy. We don't do open biopsies anymore. When I know doctors are going in and doing open biopsies for breast cancer, I am worried about them understanding what they're doing and why. The other 10% patients are usually diagnosed because we're biopsying benign disease or doing something else and find it by accident, So it might be an open breast biopsy to diagnose it, but that's not why we weren't looking for breast cancer. We were looking to treat an abscess or a cyst or a complex cyst or something else, where an open or a papilloma or some precancerous lesion, and we find breast cancer. But over 90%, the standard of care, your expectation as a patient, as a family member, is that a needle biopsy is what's done to diagnose lesions in the breast. You don't have to go through surgery. No, no, no. And then the biopsy itself now is so effective that we can characterize the type of breast cancer, and then we know what to do to treat it. This is all workflow. Let's stay in the flow. A current truth, and we're always looking for truth. Breast cancer is treated by a team. Usually the first one who sees the breast cancer is a surgeon, but even so, the imaging radiologist, their imaging specialist, is continually, from beginning to even after treatment, an important part of the team. And I work with breast radiologists who are fellowship-trained breast radiologists. So I believe Jessica Kerr knows about that. Mother works in the center, where there is a breast radiologist reading this, where basically that's all they're doing. This is the standard of care, and certainly in an urban setting like Miami, mammograms should be done at breast centers, dedicated breast centers read by breast radiologists. I'm sure they can be done well elsewhere, but as a specialist practicing, I don't work with them. Radiotherapist is often involved in the treatment of breast cancer and their new forms of radiation. A medical oncologist, or as I like to call them, chemotherapists, because they're not the only oncologists. Oncology comes in multiple flavors. There's the surgical flavor, chocolate, the best flavor. There's the radiologist, their radiotherapist flavor, and the medical oncologist flavor, which is vanilla. It's everywhere. Then, of course, there are other support personnel, which I don't mean to minimize. My physician's assistant, the geneticist, the nurses who are taking care of patients, the lymphedema therapist. I mean, you can name multiple other people who are involved intimately in the care of any particular patient that are very important parts of the team. But it's not done, again, in isolation. So it's not 1900 with Halstead at Johns Hopkins where breast cancer is only treated with a radical mastectomy. That's not the current surgeon. The current surgeon has to be integrated and know where he stands in the team that's taking care of patients. Okay, so the role of the breast surgeon is a team member, and again, as I say, he most often will see the patient first, and I'll set the workflow. I'll initiate the workflow. I'll set the treatment plan, which is standard. We have it set in guidelines like I showed you before, where I know what I need to do, and then the other team members will get involved earlier or later as their involvement in the treatment becomes necessary. So, breast surgeon is a fellowship-trained breast specialist in surgery. So I happen to be a surgical oncologist who mostly specializes in treating breast cancer, and the other flavor of a breast specialist is the fellowship-trained breast surgeon who's doing only breast diseases. And as I was talking to the women at the table, the Komen table, I mean, that's one of the things Komen does. A partner of the coalition is they provide money for fellowships to train breast surgeons, which is what we need in communities. We need specialists who know the right thing to do, when to do it, and how to do it, and work as part of the team. Now, why do I go through all this? Because I'm trying to tell you what you need as a patient, friend, family member, or survivor in order to get the best care for whoever you're concerned about, okay? I'll make the radical statement that in this community, or an urban community, really breast cancer should be handled by a breast, a fellowship-trained breast specialist as part of a specialized team of people who are doing this routinely. It has been proven in the literature with scientific studies that the outcomes are better if it's done that way. Okay, part of the problem. And I was sitting there the other day and looking at this bowl of fruit, and you say, you know what that bowl of fruit reminds me of? That bowl of fruit, and you can see there's bananas and grapes and apples and pears and oranges and nectarines and all that are in the bowl of fruit. That reminds me of breast cancer, because breast cancer isn't just one disease. It's really a bowl of fruit. And a banana is as different from an apple as an apple is from an orange. I mean, they're different. They're really different diseases that need to be treated in a different way. So, how do we treat? Surgery is the mainstay of therapy for all non-metastatic breast cancer. So if the breast cancer hasn't spread beyond the breast or lymph nodes, and this is somewhat of a radical statement, I was thinking about it, but it's true. Surgery is the mainstay of therapy. You need surgery in order to effectively treat a breast cancer. And the recommendation for what you're going to do on treatment is based on the type of tumor. There are 4 subtypes now: luminal A, luminal B, the wild type, and triple negative, and the HER2 positive breast cancer, all of which you don't need to remember, but you need to know that breast cancer is not one disease. There are genetic risks that will totally change my recommendation for what a woman has. A patient with a BRCA1 gene mutation, which some women have, 12% of breast cancer patients, I'm told, will have a BRCA mutation, and some of those will be BRCA1. Those patients really are at upwards of an 80+% risk of getting breast cancer. And they'll keep getting breast cancers. The most breast cancers I've had in one patient is 3. A young woman came in who was actually a radiology tech at one of the hospitals. She was in her 20s, and she had a poorly differentiated breast cancer. It was, quote, triple negative. There were no hormone markers or anything. And I said, oh, she was young, had a great figure. We went ahead and did lumpectomy, and she had negative lymph nodes, and she did great until 5 or 6 years later when she comes in with the cancer in the other breast. And I said, okay, well, we did the same thing on the other side. Well, another few years go by, and she comes in with a 3rd one. And I said, hold it. By now, we had some awareness that there was a genetic basis for breast cancer in certain women. I'm a surgeon, just a surgeon. So what do I know about it? Well, I have to know about it as being part of the breast cancer treatment team. And I said, hold it, something's going on here. And she tests BRCA1 positive, so we go ahead and treat her, and she's still with us now, or up to 20 years, I think. But she comes in a few years ago and she says, I'm worried about my daughter. She's 22 and she wants to get married and everything. And I said, oh my God. And the daughter tests BRCA positive, but unlike this woman or her mother or grandmother, both of whom had died of breast cancer before her, her daughter was now BRCA positive but didn't have breast cancer. So we had an opportunity. We could do something now, earlier, and she never gets breast cancer, or we could wait until she gets breast cancer and she becomes a breast cancer survivor, risking her life, which to me is, unacceptable. And I present it that way to women who have this problem. So that changes what we do. Also, tumor size, which is tumor stage, how far advanced is the tumor? For very big tumors with lymph nodes that are involved under the arm, we do one thing. For little tumors with no lymph node involvement, we do another. That's going to totally change our recommendation for treatment. For some tumors, remember, it's a bowl of fruit. For the apples, we may say, well, let's go, and we go right to surgery. But for the oranges that may benefit from treatment up front, we call it neoadjuvant therapy, we'll treat them with chemotherapy or with hormone anti-estrogen pills for older women in some tumors, and we'll shrink them or make them go away. So if a patient with a, quote, triple negative or a non-hormone sensitive tumor comes in, and these are aggressive tumors, we can expect probably upwards of a 30% or more complete response where the tumor disappears. And we know that greater than 90% of those patients will survive without recurrence. This is a radical change from when I started practice. This is one of the true advances in therapy. So timing of treatment, treatment order. I think I've talked about the other two. Okay. Other things that influence what we do, and these are tests you need to at least know you've heard the word and say, why aren't I getting these? These are things you may need. So if you have a hormone-sensitive breast cancer, they can characterize it or see what genes are turned on and off and tell you whether you'll benefit from chemotherapy or benefit from a pill or not. This is important because a lot of women are have been treated with chemotherapy with absolutely no benefit. And if we do an oncotype test on them, as is recommended in the workflow, we can find out that they're very low risk for tumor. Risk assessment is important. Adjuvant online is another test. One comment on the genes. When we started out doing, genetic testing for patients at risk for breast cancer, we were looking at BRCA1 and BRCA2. Now in my practice, I've seen 5 different genes that put women at high risk for breast cancer, and there probably will be more coming. I estimate, if the BRCA incidence in women is 12% or so, 1 in 8, that it's probably going to be 1 in 5 or 1 in 4 women, I bet, who are going to have some definable genetic basis. And this is a whole new world. And I'm going to, okay, one of the things I did also want to mention was talking with your doctor. I'm going to give people, in terms of what to expect, but I will end here now. That's me operating. Okay, questions. I wanted to leave a few minutes for questions if you had them. Speak up. Anyone have a question? Or I'll go back to my last few slides. Yes? Can I tell you a story? Okay. So there was a patient who I treated when she was 27, 28 years old, and she had a hormone-insensitive breast cancer. And then I was seeing her 8 years after her mastectomy, and she was coming in because she said, I want the other breast removed. I'm worried about it. And I said, well, your mother had breast cancer and your grandmother had breast cancer. Now we have a test to find out if it's familial. So we go ahead and find out she's BRCA1, and she has her mastectomy and then a orophorectomy, and she's doing well. But 6 months later, her father walks in, 70 years old, with a breast cancer. So yes, we treat it. It's supposed to be 1/100th, that is 1 male breast cancer patient for every 100 female patients you see. And I guess that's what I see in practice. I treat over 200 women a year with breast cancer, and we see 1 or 2 male breast cancers a year. And the treatment's a little different in the sense that we're not doing so much, we're not looking for breast conservation, although I had a general surgeon come up to me and he was proudly proclaiming how he had done a lumpectomy on a male patient with breast cancer, and I was scratching my head. I said, where does this come from? Outer space? What's the point? I mean, the whole reason to do breast conservation on a woman is, of course, cosmetic. There's no other reason. There's really no other proven reason, let's say. There can be a lot of reasons, but there's no other proven reason, but it's an equivalent treatment. You don't need to lose your breast. But for men, there's a lot less tissue to work with. The margins are a lot closer. So we want to do a mass, just get all the tissue off. The hair grows back, the grass grows over, you don't see it very much, and then the treatments thereafter are very analogous to women. We do sentinel node biopsies. We don't remove lymph nodes anymore. Everyone know what a sentinel node biopsy is? We always used to do the breast and take out all the lymph nodes, which resulted in a lot of morbidity, a lot of problems afterwards, arm swelling, difficulty moving the shoulder, discomfort. But now we use a different technique because we know that removing unaffected lymph nodes doesn't do anything for anyone, doesn't improve your outcomes. And this is, again, outcomes. We're looking at outcomes. What's the safest, best thing to do for patients? And we found that just checking a few of the lymph nodes that we call the sentinel nodes, the first nodes presumably to trap a cancer cell, that we can predict what will happen to the patient. And now the standard of care is if you have up to 2 sentinel nodes involved with tumor, you still don't need to remove the other lymph nodes. It doesn't affect your outcomes. So yes, we do that for men also now. So so now the men don't get axillary dissections. Yes? I can't hear. Except, okay, this is a misconception, when I was at the last American Society of Breast Surgeons meetings, the general consensus is for lymph node identification of the sentinel node, which is, I believe, what you're talking about. We would give an injection of radioactive tracer that we could detect with a handheld Geiger counter. It's usually either done the day before or a few hours before the study. And then at the time the patient is going to sleep, we would give an injection of blue dye. Now we're using methylene blue is what I use now, diluted. And that's right before. But the detection with the radioactive tracer is more effective, more efficient, more reliable. The blue dye supplements it. So I do both. So what's the difference? I don't know, because I do both. And I have a very high detection rate and a very low false detection rate. And that's the current consensus standard that's being done by breast surgical oncologists around the country. There is an example. There is an example of a second floor decision. It's how she feels. She's not looking, she doesn't know the outcome data, but she may have heard somewhere that something bad happened to a woman with this or that or whatnot, and then she feels in a way it's uncomfortable. But that's not a real world decision. That's an emotional decision because the data doesn't show that. She would prefer, yes, but what does she need? She wants, but what does she need? We need something that's going to give us the best way to predict if there's involvement, so we know what her stage is. We need to do it in the safest way possible. Yes? Well, you know, some insurers are easier than others, Care Plus, lots of luck, but, you know, it's, again, this is denial of services, but you're more into what you need than what you want. I mean, you're asking a legitimate question. You say, look, I have this family history, especially if you have female progeny or nieces or daughters or sisters or whatnot who aren't affected. You're not affected. So the question is do you have an affected survivor who's living who can be tested? You essentially just have the risk. You need to have a risk assessment. That's what we did, one of the things, and a number of women I see in the office have risk assessments where I actually have a program from the American Society of Breast Surgeons where we calculate what your risks are, and we can then make a case to the insurance companies to say, yes, this woman needs to have, you know, genetic testing. There's no survivor in the family. She has progeny who are at risk, and you may have other risk factors, you know, ethnic background, et cetera, you know, that just, you know, there's a straightforward way to do it that you give them an answer that even Care Plus can't refuse. This is that issue what we showed from that New England Journal article is, are they rationing care? Well, the problem here could be twofold. One is you're getting denied something you need, and the other problem is that, you know, someone isn't really explaining to you what's going on very well. And so is it confusion or is it denial of service? And that's a long discussion that you need to have with your physician, you know. Yeah. Any other questions?
I have a question for Dr. Weingrad.
Uh-oh. Uh-oh.
And he's right. He's an on-hand doctor. Like he said, we come in on the second floor. He's on the bottom level. And I've had him roll his chair back and tell me what you want, but I'm going to tell you what you need. And I remember coming in your office the second time I was diagnosed with breast cancer, and he told me, he said, tell me what you want, I'm going to tell you what you need. And by being my second bout with breast cancer, he told me, you need a second. That's what you need if you want. But me and my husband are making a decision. We want to move forward. But Dr. Weingrad is great. I just want to give you the
Thank you. I'm embarrassed. Okay. That, you know, one I didn't get to is I'm about to get stopped, but Russell owes me some time. He does. I'm about to get stopped. But is talking with your doctor. I mean, my physician's assistant and I have been doing this together for about 5 or 6 years, and we realized that a lot of times we go in and patients would be resistant to treatments or they wouldn't show up for therapies or whatnot, and we realized that we weren't listening. We were hearing what they were saying, but we weren't listening to them because they were talking on a total level. So once we switched to this, once we climbed the stairs to the second floor and started listening, then the interaction became easy and we listened. We were listening. And, you know, you have to get your doctor to get to the second floor. If he's not considering, any one of you have seen that movie, The Doctor, where, you know, the famous cardiac surgeon in the movie, you know, has who's played by William Hurt, has a throat cancer. And then he meets up with the doctor and says, oh, you have throat cancer. We're going to have to cut your throat out. And that was the discussion. I mean, that is so far. That's in the basement, you know. That's not even on the first floor. But it doesn't work. I mean, human beings are just much too complex. I mean, let me tell you, part of what supports the house and keeps the house standing is really the power that emanates from the top floor. And we really need to look up. And you need, as patients, survivors, family members, caregivers, you need to have someone who's going to interact with you at all levels, okay? And that's important. So thank you all for listening. I hope I didn't bore you too much. Okay.